everyone, today I am here with another lecture of our series of IPL, 30 questions in 30 minutes. Today we will study anatomy and Mullerian anomalies. Let's start with Mullerian anomalies first. So, before studying Mullerian anomaly, we have to know a little about the embryological development of our urogenital system. So, when a urogenital system is formed, basically three players are there: mesonephric duct, urogenital sinus and Mullerian duct. So, all these three together form the urogenital system. Mesonephric duct is the one which forms male genitalia and also the renal excretory system, not the kidney. So, kidney is by metanephros, but after kidney, whatever urine is being collected and excreted, that is by mesonephric duct. Mullerian tubercle is the one which forms mainly the male-female genital system. Urogenital sinus partially helps both of them. Let's see what all does mesonephric duct forms. It forms in renal excretory system, it forms collecting tubules, calyces, ureter and trigone. Remember it by mnemonic clear cut, and as such also it should be clear cut in your mind. So, mesonephric duct forms clear cut, collecting tubules, calyces, ureter and trigone. In male genital system, remember by the mnemonic seed. It forms seminal vesicle, epididymis, ejaculatory duct and vas deferens. That's what it forms in male genital system. You talk about Mullerian duct, it forms female genital system. How to remember? U for uterus and C, two tubes. So, Mullerian duct contributes to female genital system. It forms uterus, tubes and upper two-thirds of vagina. Now, let's see what does urogenital sinus contributes to. See, after trigone, the renal system is incomplete. And here also, after upper two-thirds of vagina, who is forming the lower part? The urogenital sinus. So, urogenital sinus forms bladder except the trigonal area, urethra and the lower one-third of vagina. So, that is how it's contributing to renal system and the female genital system both. So, these three forms your urogenital system. Okay. Now, let's go further. Remnants of Wolffian duct have been asked in NEET. So, Wolffian duct, which is the mesonephric duct, is degenerates in female genital system. Mullerian duct forms everything. So, where does it lie? Mullerian ducts lie centrally and the mesonephric duct is lying paracentrally. It lies lateral to the Mullerian duct, and that is where the remnants will lie, obviously. So, remnants can be, depending on location, can be cranial and can be caudal. So, cranial is around the ovary and hence they are called epophoron and paraophoron because they are above and below the ovary. The caudal one is a very common duct, Gartner's duct. Obstruction of this duct only leads to Gartner's cyst. Now, the question asked was, where do they lie? They lie in the lateral wall. Gartner duct lie in the lateral one-third of uterus and lateral wall of vagina. That's where it lies. And paraophoron and epophoron, they also lie on the lateral wall of the uterus. Okay, this is where their location is. Next, now we'll discuss the Mullerian anomalies. Now, Mullerian anomalies by ACOG have been comfortably divided into 4 classes, and that's we'll go one by one. But Escher has divided Mullerian anomalies into 7 classes. I have never seen a question asked based on the class that which anomaly, but still if you think you should know about it, there is a mnemonic. Anomalous uterus does bring sadness. So, Mullerian anomalies, remember anomalous uterus, obviously it brings sadness. So, first is agenesis of the Mullerian tract, which involves MRKH also. U say unicornuate uterus, D say uterus diadelphus, B say bicornuate uterus. With sadness, remember septate uterus, arcuate uterus and DES abnormalities. Okay. Agenesis, unicornuate uterus, diadelphous uterus, bicornuate uterus and septate, arcuate and DS related abnormalities. Though this is the 7 classes of Escher. Now, class 1 disorders. Now, we are discussing basically the according to ACOG classification. So, class 1 disorders are dysgenesis. Like Escher, it is also dysgenesis. Dysgenesis can be partial or complete. Complete dysgenesis of genital tract is called as MRKH syndrome. Now, question have been asked on MRKH syndrome INI 2021. So, presentation was given and options were given. What is the diagnosis? So, XX female phenotype externally, but there is agenesis of uterus and upper vagina, hence primary amenorrhea. There is no uterus, so there will be no cryptomenorrhea, no cyclical pain. And lower one-third of vagina is formed because it is from urogenital sinus, so there will be small blind vaginal pouch that will be there. No cyclical pain. You need to do karyotype of such patient because you need to differentiate it from androgen insensitivity syndrome. AIS also presents similarly except one thing. They do not have pubic and axillary hair which are there in MRKH. But for diagnosis, you need karyotype because AIS are XY. You also need IVP because It is agenesis of genital tract, which develops in very close relation to the urinary system. So it is very commonly associated with renal agent. So you need IVP also. Then how will patient become pregnant? If you want to treat MRKH, she has healthy ovaries and healthy ovum. She can very well have baby by surrogacy. Main problem of MRKH is they cannot have a comfortable coitus because of small dimpled vagina. So vaginal dilatation using serial dilators and McIndovaginoplasty. This is your first option. That is your option. So that is your treatment for MRKH patient. Class 2. Class 2 are transverse fusion defects. So like Escher does not have this class. So here class 2 has transverse fusion defects which include transverse vaginal septum and cervical agenesis both. Imperforate hymen is not a Mullerian anomaly. It's not in there in class. Hymen is not apart from Mullerian duct. It's an area between where the urogenital sinus is meeting the Mullerian tubercle. It is not part of Mullerian, Mullerian ducts. That is why it is not involved in Mullerian anomalies. Class 2 involves transverse septum and cervical agenesis. A lot of questions have been asked on these also. How the patient will present? Patient has uterus but the bleeding is not coming out. So patient will have cryptomenorrhea. It is XX, female phenotype, right? But cryptomenorrhea. There will be lump abdomen because of the blood being collected in the uterus. Ultrasound and MRI can be used for diagnosing the patient. Now the question that has been asked in NEET 2020 was, how will you differentiate it from imperforate hymen? The scenario given was female phenotype with cyclical pain, but one thing given was vulval lump. Vulval lump will only be present in imperforate hymen. Cervical agenesis or transverse vaginal septum present like this soft tissue mass. They do not have a vulval lump. Hymen is a very thin membrane. All the blood being collected above it in the vagina will present as lump. Here it's a muscular septum. It will not bulge with the blood above. Okay. So if vulval lump is mentioned, it is imperforate hymen. In NEET 2023, again this question was asked with same presentation of cryptomenorrhea, abdominal lump because of uterus. One thing was given, in PR there was fullness in whole vaginal length. The diagnosis, again imperforate hymen. In imperforate hymen, whole vagina is filled with blood. So you can feel fullness in vagina. Cervical agenesis, will there be vaginal fullness? Cervix is agenetic. How the vagina will have blood? So it cannot be there. In another option was vaginal agenesis. No, vagina is agenetic. How the blood will be there in the vaginal canal? Again, it cannot be there. Another option was high transverse vaginal septum. In high transverse vaginal septum, exactly how will blood will collect in the vagina? So the answer was imperforate hymen, in which there will be vaginal fullness in whole of the vaginal length. The complications which can occur is because of basically cryptomenorrhea. That is why it has to be treated fast. It can lead to endometriosis because of the regurgitated blood, endometriosis, dysmenorrhea, and even infertility because of so much blood being regurgitated out. So that's how it will present. So complications have been asked in NEET 2021. So what complications occur? There occur infertility and endometriosis is the complication of transverse defect. This is class 2 disorders. Class 3 disorders are disorders of lateral fusion. Escher basically has so many classes because they separated bicornuate, didelphys and septate. Here, everything is in class 3 disorder. Disorders of lateral fusion, which is didelphys, when nothing has fused, 2 vagina, 2 cervix, 2 uterus. Bicornuate, bicollis, vagina has fused but cervix and uterine body are separate. Bicornuate, unicollis, 1 cervix, 2 uterine bodies. Septum and unicornuate uterus. Unicornuate means only one Mullerian duct has formed and another one has degenerated. So here only one tube will be there. That is the sign of unicornuate uterus, right? How will patient present? So patient will be having difficulty in using tempus. Patient will have difficulty in having coitus. There are 2 uterine cavities, so there will be heavy menstrual flow and dysmenorrhea, but there will be not endometriosis. Why I am mentioning that? There was again a question was asked on how to diagnose uterine didelphys in NEET 2021. So the question was, what are the complications in a patient of uterine didelphys? There were certain obstetric complications and certain gynecological, heavy menstrual flow, dysmenorrhea were there. Endometriosis is not a problem with lateral fusion defect. It's a problem with transverse fusion defect. So that was the answer. Pregnancy can occur. So one way of diagnosis is that you have inserted IUCD, but despite that pregnancy occurred in another horn. That's how you can diagnose also. But how will you exactly diagnose the Mullerian anomalies? So to diagnose the Mullerian anomalies, you need certain tests. Like HSG is one of them, TVS is one of them, then MRI, 3D ultrasound and hysterolaparoscopy. Now 2 times different kind of questions have been asked, both of them. So basically in INI, the question given was that patient has unicornuate uterus what all methods can be used for diagnosis. So there were multiple methods given. You were supposed to choose 2 or 3. So there were the options were TVS, X-ray, hysterolapro and falloposcopy. So TVS can be used, hysterolapro is used, but falloposcopy is for fallopian tubes and X-ray cannot diagnose Mullerian anomalies. Okay, HSG is different. X-ray cannot see uterus. Hence, these 2 were the answer. Now, this was one question. Another question was asked in NEET 2021. NEET 2021 asked basically a patient with recurrent abortion is suspected to have Mullerian anomalies. How will you confirm? Now, here the question is, among all these tests, which is the confirmatory? The confirmatory for Mullerian anomaly, just know for all time, is 3D ultrasound. 3D ultrasound is used for confirmation. But in that question, 3D ultrasound was not there. In that case, they had CECT, they had HSG, they had, I think, ultrasound, but the answer was hysterolaparoscopy. If 3D ultrasound is not there, your second best option for confirming is hysterolaparoscopy together. Only hysteroscopy will not tell you anything, only laparoscopy will not tell you anything. So, hysterolapro together will confirm your diagnosis. Obstetric complications that can occur, obviously, the space is less, so recurrent abortion, preterm labor can be there, associated cervical incompetency is there, abnormal presentation in pregnancy is there. That was the question of uterus diadelphys, in which obstetric complications of recurrent abortion was there. What cannot occur is endometriosis, right? Okay, yeah. Now, uterine septum resection question has been asked on how the uterine septum is managed. It was first asked in NEET 2020. I don't know why, but the name of the operation was given in the options, but that was little unwanted, but still now it was mentioned, so you should know about them. So basically all the operations, what do you have to do? You have to remove the septum and create a better cavity. It can be done abdominally or vaginally. The abdominally 2 operations are done, Jones metroplasty and Tompkins metroplasty. In both of them you don't need to know much, you just open the abdomen, laparotomy is done, cut the septum, stitch the remaining uterine septum and operation is done. Another one is vaginal, in which you hysteroscopically just cut the uterine septum. The muscular wall of the uterus is not removed. So the question asked was, which has a better obstetric outcome? Now you can know, here a big cut on the uterus is made, the muscular area is removed, then it is stitched. High chances of infertility, high chances that in pregnancy uterine rupture can occur. These patients can never undergo vaginal delivery. Whereas in hysteroscopic resection, you are just going vaginally, cutting the septum, all of the other uterine wall is safe. So this has a very good obstetric outcome. In NEET 2021, I think some awareness came into the examiner. The same question was asked, but they said, which is the method of removing a uterine septum. They asked the route of septal resection. The options were laparotomy, laparoscopy or hysteroscopically. So the answer was hysteroscopically. There the name of these operations were not done. Okay. Still, if you want to remember the name, you can remember the name by Happy Tojo. Happy Tojo is for vaginal, for uterine septum resection. Hysteroscopy, Tompkins and Jones metroplasty. Okay, we have seen that the septum is removed and such a big cut is made and uterus is stitched. That is why they don't have good obstetric outcome. Whereas here, just the resection is done. It can be done using scissor or a resectoscope or even laser. Okay. Points to remember in relation to Mullerian anomalies. Most questions have been asked on all of them. Most common anomaly is septate uterus. I'll not say arcuate because arcuate is now considered a variety of septate uterus. Worst obstetric outcome is of unicornate uterus. Remember, best is of uterus diadelphys. It is not of septate, it is of uterus diadelphys. Even uterus diadelphys, the surgery is not done. You do not do surgery in uterus diadelphys as you cannot combine both of them since vagina are also two and it has best outcome. Gold standard we have discussed for diagnosis is 3D ultrasound. Overall successful pregnancy rate in Mullerian if no treatment has been done is 25%. But if you have treated the patient, it is 70 to 80%. Very commonly associated with 2 other anomalies, renal and spinal. Hence, all the patient of Mullerian anomalies has to undergo IVP and X-ray spine because of these common anomalies. Okay? Right. Now, hysterosalpingography, n number of questions have been asked on that. So, HSG is a way to diagnose, not confirming the diagnosis, to predict Mullerian anomaly. Basically, HSG is a test done for infertility. Mullerian anomaly can be easily delineated on HSG. This is the Leach-Wilkinson cannula asked in NEET used for HSG. What do you do in HSG? Hysterosalpingography. You inject a radio-opaque dye and you take X-ray picture. As the dye travels to the uterus and the tube, you see the clear picture of everything. So, thin tubes and you see peritoneal spill. Peritoneal spill means dye is spilling in the peritoneum. It means the tubes are patent. It's a good sign. Okay, that's how a normal picture looks like. Now, a lot of questions have been asked on HSG. So when you see HSG, you need to see 4 things. Cannula being used. That will tell you how many vagina patient has. Cervix. And then the uterine horn. Is it a single cavity like this or there are 2 uterine bodies? If there are 2 uterine bodies, what is the angle between them? These 4 things will tell you the diagnosis. So 2 vagina. So how will you know 2 vagina? There will be 2 Leach-Wilkinson cannula. 2 vagina means uterus diadelphus. Uterus diadelphus is the one which has 2 vagina. I understand that bicornuate uterus can also sometimes have septate vagina, but see, examiners, they are not sitting there to make you so confused that you are not able to answer. They will not ask such rare presentation. 2 vagina for you as an undergraduate is uterus diadelphus. Okay. Now suppose 1 vagina is there, but you can see 2 cervix. Uterus bicornuate, bicol is simple. Problem arise here. When 1 vagina, 1 cervix, but 2 uterine horns. Uterus bicornuate unicolous. 1 cervix, 1 vagina, 2 horns again. Septate uterus. They both present similarly. How you differentiate? By seeing the angle between the horns. Now you cannot measure the angle in the exam. The idea is that if they are far behind, if the uterine 2 bodies are very far, look far to you, the distance between them is more than 4 cm. It is uterus bicornuate. If the 2 bodies seem closer to you, it is septate uterus. Simple. Now what is this? See, can you see 2 cannulas? So 2 vaginas. Simple. Uterus diadelphus. Here single vagina. But can you see 2 cervix? It is uterus bicornuate bicollis. Now here, single vagina, single cervix, but 2 uterine horns. Can you see how far they are? This is uterus bicornuate unicollis. Uterine septum, again, very similar picture like this, but the horns are close by, acute angle. This is uterine septum. Okay. Now the question have been asked on both of them. The HSG, uterine bicornuate uterus, was asked in 2022 NEET. And other 2 were also asked. Let's see what were they. This was asked in NEET 2020. This picture was given. So see, this is normal uterus, thread-like tubes. Now see this, dilated tubes with no spill. Peritoneal spill is not there of the diet, means distal obstruction is there. The tubes are dilated and thick, so it is hydrosalpinx. Okay, this is hydrosalpinx asked in NEET 2020. One another option in the same question was of Cornwall block. So Cornwall block looks like this. Here the dye will not even fill into the tube because there is block at the cornua. Okay, so this is how a Cornwall block will look like. Okay. Now this unicornate horn was the question asked in 2021 NEET. So this is unicornate horn. Can you see a single deviated uterine cavity with single tube? There is single tube. Single tube is a sign of unicornate horn. Now the question asked basically in 2021 was that this is the picture, what is the test done? They basically asked what is this test. So dye is seen, cannula is seen, it is HSG. Another option was sonosalpingography. Sonosalpingography is nothing but the ultrasound in which you insert the saline and you take the ultrasound picture. Basically, when you insert the saline, the cavity opens up and the intrauterine pathologies can be easily clearly seen. That's what the sonosalpingography is. This is sonosalpingography. This is not. One another option was genitoscopy. So what it is? Basically, so one another option was genitogram. So what is genitogram? Basically, just like HSG, you insert a catheter into just the lower perineal area and you insert the dye. It is done in kids when you want to exclude presence of any intersex. When you are suspecting intersex, you want to see connection between the vagina and the bladder. So see, only the lower vaginal tract, only the lower genital tract is visible by genitoscopy. This is what it is, done in babies where you cannot insert deep big cannulas. Okay, so this is what it was. So this was the question asked. So we have finished the Mullerian anomalies. Now we will start with the anatomy of female genital tract. Okay. So first question asked in NEET was about the version and the flexion of the uterus. So why it was asked? Basically the angle of anteversion and flexion, they are the passive supports of uterus and they have a role in preventing the uterine prolapse. So what is version? Version is the angle between the uterine body and the vagina. So between the uterus and the vagina is version, whereas flexion is the angle between the uterine body and the cervix. It's an angle within the uterus, it's an angle between the uterus and vagina. So version is an angle of 90 degree. Normal angle was asked in NEET. So version has normal angle of 90 degree. That is why in a lithotomy position, because of this angle, the uterus tend to lie more horizontally. And because of this angle, the direct impact of intra-abdominal contents is not put on the vaginal axis and hence the prolapse is prevented. So this is 90 degree angle. the flexion is the angle of 125 degree, very well maintained by the supporting ligaments of the uterus. Another question which was asked in INI 2021 was about uterocervical length. So see, in anatomy of female genital tract, we will cover only those topics on which questions have been asked in past. Okay. Otherwise, anatomy is very vast, but we are here to cover only the important topics. So uterocervical length was asked in INI 2021. So why knowing uterocervical length is so important? So when you are doing any DNC procedure, always before doing any uterine procedure, be it DNC or be it history, anything, you have to take uterocervical length. Why? Because if you will not know it, there are chances you might perforate the uterine wall. So you should know first the average uterine cervical length in an average woman. Besides that, you still take the UCL to know any variation in the size. Okay. So see, uterus in a general reproductive age woman measures almost 5 cm in length, and half is the cervix, which is 2.5 to 3 cm. So ratio of uterus to cervix is 1:2 in reproductive age women. Whereas in the neonate, this ratio is reversed. It is 2:1. The cervix is larger compared to the uterus. So this is cervix and this is uterus. Yeah. So cervix to uterus ratio is 1:2 in reproductive age female, whereas in neonates it's 2:1. In menopause it is 1:1 to again 2:1. Right? So uterus is almost 5 cm and cervix is 2.5. So the average UCL length in a reproductive age female is 7 to 8 cm. This is the average length. Whereas it is reduced to almost 5 cm in a postmenopausal woman. So postmenopausal woman UCL length can be asked 4 to 5 cm because it's a small uterus. So you need to use smaller instrument when you are doing any intrauterine procedure. Let's know some other sizes also in female genital tract. Fallopian tubes is 7 to 12 cm, whereas ovary is 5 into 3 into 3 cm in a reproductive age woman. In menopause, it is reduced to 2 into 1 into 1 cm. Right? Okay. Now, questions have been asked on the variations of hymen. So, first of all, what is hymen? Now, hymen is the area which lies where your UV canal meets the urogenital sinus. When your UV canal, which is forming upper 2/3 of vagina, meets the urogenital sinus, which is forming lower 1/3 of vagina, this junction has a thin membrane called as hymen. Hymen is not a completely closed membrane. It's a crescentric membrane. In a normal female, it's crescentric. Okay, but there can be different variations in its shape. So, there can be annular hymen. As such, it's just a variation. It is not pathologically important. But there are other important hymens also, like this one, imperforate hymen, microperforate hymen, cribriform or septate hymen. All these have a tendency to cause, so this, it's the most common cause of cryptomenorrhea, imperforate hymen. We have read it just few minutes back. So this can cause cryptomenorrhea and all kind of problems. Rest all will not cause cryptomenorrhea, but there will be problems with difficulty in using tampons and difficulty in coitus. So this question again has been asked in NEET last year. So they gave you the image and they asked which type of hymen it is. Now another question which was asked in NEET 2022 that same year was, they gave you this pelvic structure and they asked which plane is this green one. So it's not a tough question, but knowing this, which plane is this, you should know little more detail about the planes in the pelvis. So pelvis is like a cavity. It has few planes. So plane is a two-dimensional structure. It's a plane, two-dimensional, and certain segments. Segments is a 3D cavity. So between planes, so this is one plane, this is one plane, between it lies a segment, a cavity. So it has certain planes and certain segments. Like inlet. Inlet is a plane. It's a two-dimensional plane. When your biparietal diameter crosses this inlet, we say engagement has occurred. So it's a plane which extends from upper border of pubic symphysis to the sacral promontory. It's a plane. The pelvic cavity is a segment. It's an area, three-dimensional area, which lies between what? It lies between this plane of inlet, between this and this plane, this green plane. This large area is your cavity. This plane, which is forming the floor of the cavity, is the plane of least pelvic dimension. It is nothing but the floor of your cavity. So this huge area is the cavity. So above is inlet plane, lower down is the plane of least pelvic dimension. Now plane of least pelvic dimension extends from the midpoint of the pubic symphysis up to the tips of sacrum, you can say. So up till tip of sacrum, to the lower border of pubic symphysis is plane of least pelvic dimension, and it passes through the ischial spine. Can you see? It passes through the ischial spine. So this plane lies around the area of ischial spine and it's the smallest area in the pelvis, hence called as plane of least pelvic dimension. Now, this large cavity has a plane of itself also. So, this is a cavity above which lies a plane, below it also lies a plane. Inside this cavity, inside this segment is also a big plane, a big two-dimensional plane called as this one. This is the plane of greatest pelvic dimension. Sorry, just pardon my drawing. This is the plane of greatest pelvic dimension. It is lying within the cavity. Plane of greatest pelvic dimension is big, almost 12.5 centimeter. It lies from midpoint of pubic symphysis to S2, S3. Okay, and it is lying in the cavity. So, we have discussed three planes and we have discussed one segment, which is cavity. Let's come to outlet. Outlet, again, the obstetric outlet is again a segment. Like the cavity, it's a segment, it's an area which lies between the roof is by plane of least pelvic dimension and the floor is by another plane here, which is your anatomical outlet. Anatomical outlet is again a plane and between these two lies obstetric outlet. So, we have two segments and we have 4 planes. So, in a pelvis, we have 4 planes and we have 2 segments, or you can say 2 cavities. So, plane of least pelvic dimension we have discussed extend from here to tip of sacrum. Anatomical outlet extends from lower border again of pubic symphysis to the tip of coccyx. Between these two lie your obstetric outlet. Okay, I hope it's clear. Let's see in this image. So, we have 4 planes. Inlet, plane of greatest pelvic dimension from S2, S3, which is lying within the cavity. Plane of least pelvic dimension, which is forming the floor of the cavity and roof of the outlet, and the anatomical outlet. This is again a plane which is forming the floor of the outlet. Okay, this segment is your pelvic cavity and this segment is your outlet. Easy. So, let's see. The question was asked, what is this plane? So, see, it is extending from lower border to tip of sacrum. This is plane of least pelvic dimension. If asked this one, from mid point of pubic symphysis to S2, S3, this is plane of greatest pelvic dimension. This is plane of inlet. This is plane of, drawn like this is plane of anatomical outlet. Okay, right. So, this was asked in last NEET. Few lines about pelvic diaphragm. On pelvic diaphragm, a lot of questions have been asked how it is formed. It is a muscular partition lying between the pelvis above and the pubic and the perineum below. So, it's a muscular partition made of levator ani plus coccygeus. Coccygeus and levator ani together form pelvic diaphragm. Coccygeus is not a part of levator ani. What role does it play? It plays a very important role in containing all your abdominal and pelvic organs within the cavity. It prevents the prolapse, it helps in defecation, urination, and it also helps in labor. So, that's what the role is. How the question has been asked in NEET, how the levator ani is formed. So, see this is your pelvis, you are seeing from above. Now, the levator ani is a muscular sheet made of 3 muscles. One is pubococcygeus. So, pubococcygeus fibers run downwards and backwards. That is the direction of levator ani, downwards and backwards. So, pubococcygeus, iliococcygeus, from ilium to coccyx, and the medial most fiber of pubococcygeus are called as puborectalis. These 3 are together forming levator ani. This muscle, and where are they originating from? They are originating from a white line called as arcus tendineus levator ani. This is the origination point, and where it is, where the white line is actually lying, it is actually on the muscle obturator internus. The fascia on the obturator internus muscle gets thickened, forming a white line, which gives origination to this levator ani muscle, right? The muscle which is lying behind, which is coccygeus, which is arising from ischial spine, not from white line, is coccygeus. It is a part of pelvic diaphragm. It is not a part of levator ani. That was the question. Which of these do not form levator ani? It is coccygeus. Now, this muscle piriformis is the posterior most. It does not form pelvic diaphragm. It does not form the part of your levator ani. So, this is about piriformis. Can you see this muscle whole? It's a sheet of muscle separating from pelvis above to the perineum below. This anteriorly, can you see this area? This is little depressed. It's a muscle sheet lying below levator ani. It is providing the support to the anterior structures, the urethra and the vagina. It is your urogenital diaphragm now. Urogenital diaphragm is lying in the perineum because everything below levator ani is perineum. So, it's lying in the perineum anteriorly to support the anterior structures. So, this is your uterus. So, if you are seeing from above the pelvis, this is your uterus. Near the vagina, near the mid 1/3 to lower 1/3 of vagina, if you remove this, lie this levator ani. It's like a support to the lower half of the vagina. And this was the muscle pubococcygeus, the medial fiber puborectalis, this was ischiococcygis, behind was coccygeus, right? Okay, now let's talk about the perineum. When you are talking about perineum, you need to turn this pelvis and need to see from below. Now you are seeing from below. You are seeing from the thigh area. Okay, so this was levator ani. When we are talking about what was the muscle below levator ani lying anteriorly was urogenital diaphragm. This is the fascia which is covering urogenital diaphragm. Muscles are covered by fascia. So urogenital diaphragm has a fascia above and has a fascia below. The fascia below the urogenital diaphragm covering the inferior surface is perineal membrane. Okay, so this is your perineal membrane. Everything above the perineal membrane is deep perineal pouch. Everything below the perineal membrane is superficial perineal pouch. Okay, so superficial perineal pouch is the one whose roof is formed by perineal membrane. Once you remove the perineal membrane, what you see is the deep perineal pouch. Okay, so contents of the pouches have been asked very frequently. So superficial perineal pouch, can you see this white membrane? This is nothing but the perineal membrane which is forming the roof of the pouch. You are right now lying in the superficial perineal pouch. You can see the superficial perineal pouch. It has 3 muscles, 2 erectile bodies and 1 gland. So 3 muscles, what are the 3 muscles you can see? You can see bulbocavernous, you can see ischio-cavernous and you can see superficial transverse perineum. Everything is superficial. So these 3 muscles, bulbocavernous, ischio-cavernous, superficial transverse perineum are the content of your superficial perineal pouch whose roof is formed by perineal membrane. And floor is by the fascia. You have removed that fascia, that is why you are able to see this perineal pouch. There are 2 erectile bodies, one is the vestibular body and one is the clitoral body. Clitoral body lies here, crus of clitoris lies below ischio-cavernous and the vestibular body lies below the bulbocavernous muscle. Both play a role during the coitus in bringing the orgasmic contractions of the muscle. Right. There is vestibular gland which lies just behind the vestibular body. Here it lies the vestibular gland which helps in secreting the alkaline secretions during the coital act. So this is the content of perineal pouch, important, asked in NEET. Now if you will remove this perineal membrane, can you see this muscular layer? It is nothing but urogenital diaphragm because this perineal membrane was the inferior layer of urogenital diaphragm. Once you have removed this, you can see urogenital diaphragm. Above it is the superficial layer of your fascia. So now you have encountered the deep perineal pouch. Deep perineal pouch is nothing but your urogenital diaphragm. Your urogenital diaphragm is actually the content of the deep perineal pouch. What I have told you that everything above perineal membrane is the deep pouch. So this area you are seeing is the deep perineal pouch. What are the muscles forming deep perineal pouch? Same, which are forming urogenital diaphragm, which is deep transverse perineal and sphincter urethrae. These 2 muscles form urogenital diaphragm. These 2 muscles are the content of deep perineal pouch. Right? Easy. This was the question asked that tell the structure label 3, which has been labeled 3. So this was the question asked in INICET 2021. So now we have read about the pelvis and the perineum. Let's start identifying. So this is the vagina. In the lower 1/3 of vagina, what is this area? This big sheet of muscle is your levator ani. This medial most part of levator ani, which is marked pink, is puborectalis. Okay. Now this is obturator internus muscle, from where the levator ani is originating. This is obturator internus. Below the levator ani, this structure is lying below the levator ani. So what it is? It is urogenital diaphragm. Your 2 is urogenital diaphragm. Everything, now this layer which is covering the inferior layer of urogenital diaphragm will be perineal membrane. Everything below it, this small area will be the superficial perineal pouch. This is your deep perineal pouch. Easy. What is layer 3? So this red layer covering the bladder, the uterus, reaching up to levator ani is nothing but your endopelvic fascia. The fascia which is tightly covering the pelvic organs and the muscle is endopelvic fascia. It is the one which is condensed at places and providing strong support to the uterus. And through this endopelvic fascia, the condensations, through them your arteries and nerves tend to cross and reach the pelvic organ. So these are important structures in providing support and passage to your nerves and arteries. So this was the question in INICET 2021. Let's have a little talk about perineal body. So perineal body is a triangular structure lying in the superficial perineal pouch here. It provides this, it separates your urogenital area from the anal area and provides this support to the perineal structures. Question asked is what is making perineal body? So you tell me what is making perineal body. This blue muscle which is superficial and deep transverse perineal. So 4 muscles, superficial and deep transverse perineal. Green one, bulbocavernous. This is making the perineal body, and this red one, external anal sphincter. These 7 muscles form perineal body. Ischio-cavernous does not take part in formation of perineal body. Okay? Yeah. Pelvic blood supply, another very important topic to be dealt with. So pelvic blood supply is basically by internal iliac artery. Now, internal iliac artery has anterior and posterior branch. Basically, the anterior branch provides supply to all the pelvic areas. It has, so you can divide internal iliac artery branches into vesical, visceral and parietal. Vesical are two, superior and inferior vesical, and one is obliterated umbilical artery. So, superior and inferior vesical artery are from anterior division. Visceral means providing supply to your viscera, uterine, vaginal and middle rectum. Which viscera? Which is lying in the pelvis. Uterus, vagina and rectum. Uterine, vaginal and middle rectum. Parietal means to the body wall. What is there? Obturator, internal pudendal, inferior gluteal. Okay, obturator, internal pudendal, inferior gluteal, these are the parietal branches. If you talk of posterior branches, it has only 3 branches and provide blood supply only to the pelvic walls. So, parietal branches only. Superior gluteal, lateral sacral and iliolumbar. So, again revise, anterior has basically branches into vesical, which has superior and inferior vesicle and umbilical artery. Then visceral to uterine branch, vaginal branch and middle rectal branch. Then parietal to the wall, obturator branch, internal pudendal and inferior gluteal. The posterior one has only parietal branches. Superior gluteal, lateral sacral and iliolumbar. Remember it by pills. I think remembering so much in MBBS, you actually need some pills. So remember it by pills. Posterior has branch of iliolumbar, lateral sacral and superior gluteal. Okay, right. Few lines about ureter before ending this anatomy. Ureter is very important. So ureter is a almost 20 to 25 centimeter longitudinal structure. Half lie in abdomen, half lie in pelvis. From pelvis, where the pelvic ureter starts, at the junction of internal and external iliac artery, from there to the bladder is the pelvic ureter. 95% of time, the injury of ureter, the iatrogenic injury is in pelvic ureter. That is why it is dealt by gynecologists also. So, the questions basically asked on ureteric injuries are the most common site. So, there are various sites where your ureter can get injured. One is where when you are ligating IP ligament, where it is crossed by ovarian artery, there it can get injured. Then it can get injured when it is crossing when it is very near to uterosacral ligament. Then it can get injured when it is very close to cervix and being crossed by uterine artery. Then it can get injured in the McEnroe ligament also. But the most common site is at the ligation of cardinal ligaments, where it is being crossed by uterine vessels, because it is only 1.5 centimeter lateral to cervix. It is so close. When you are doing hysterectomy, trying to ligate uterine vessels, you can very well injure uterus. This is the most common site. Most common procedure, laparoscopic hysterectomy. When you are doing laparoscopy, most commonly the ureteric injury occurs that time. If you are not asked the route, so this is the route, most common route which can cause ureteric injury is laparoscopy. If you are asked the procedure, which hysterectomy cause the most common ureteric injury, it's Vardine. So which hysterectomy is Vardine's, but which route? Laparoscopic. Most common type is obstruction. And when do you diagnose? Equal. You can diagnose it intraoperatively and postoperatively both. Okay. So this was all about the anatomy. We have covered all the important questions asked in last 5 years. Next, we will meet with some new topic. Till then, bye-bye.